The age that women should start getting mammograms has never really changed from the perspective of healthcare professionals. There's tons of data and research that has shown that starting at age 40 and yearly thereafter is the best way to detect breast cancer early and gives women of all those age groups the best chance of survival if they do develop breast cancer through early detection. What has not been consistent is that starting in 2009 and then again in 2016, a number of these task forces, such as American Cancer Society, the United States Prevention Service Task Force, started putting out guidelines that differed from that. And these were basically prioritizing different endpoints like anxiety, like false positives, like cost saving. We have known all along that the optimal way to screen women for breast cancer with the highest chance of survival is at age 40 and continuing yearly thereafter. And those two other organizations just are not up to speed on that. So the interesting part of the United States Prevention Service Task Force guidelines is that, again, those of us who are healthcare professionals have stuck with the 40 and yearly thereafter for a very long time now, based on clear-cut data that this saves lives. Back in 2009 and then 2016 reaffirmed, the Prevention Service Task Force recommended against doing mammograms in the 40 to 49 age group, and only every other year after that. And those of us who take care of breast cancer patients for a living and who are passionate about saving lives and minimizing downsides from breast cancer diagnosis felt that this was egregious. And again, this was really putting forward and prioritizing different endpoints. Again, like cost saving, like false positives, and minimizing those, and anxiety. And this was really, these guidelines that they had put forward really ignored the vast amount of data showing that mammograms every year, starting at age 40, save lives. The most recent reversion back is one step in the right direction, which is again recommending 4 mammograms starting at age 40, but they didn't go far enough in that really they're still sticking with every 2 years, which truly makes no sense to us because in the younger age groups, especially 40 to 49, cancers can be more aggressive and can grow more rapidly. So doing a mammogram every 2 years makes no sense in the setting of a potentially rapidly growing cancer. 2 years is too long of an interval, we feel, to really optimize early detection. One of the reasons for the change from the USPSTF task force was newer data showing that, very, very disturbingly, Black women who we know can develop cancers younger and are more at risk for developing a particularly aggressive kind of breast cancer called triple negative breast cancer that can grow more rapidly. And the death rate in Black women who get breast cancer is substantively and unacceptably higher. And so this change in recommendation is the USPSTF's limited response to that data, saying one thing we can do to address that is revert back to starting women younger. Again, they didn't go far enough by ensuring that what we all know, which is mammograms every year are much more efficacious in picking up cancers earlier, especially aggressive cancers. A 2-year interval is way too long. A lot can happen to a cancer in 2 years. A lot can progress. And we don't want to put our young patients, Black women, any women, at risk for a rapidly progressing breast cancer that isn't picked up. So, one of the biggest issues that is very specific to Black women is what we know now in 2023 is that breast cancer isn't just one disease. Breast cancer involves multiple different, what I call subtypes. And each of these different subtypes is treated differently, has a different pathway, and behaves differently. Well, one of these subtypes of breast cancer is called triple negative breast cancer. It's the most aggressive kind of breast cancer and also one of the most difficult to treat. So what we know is that of all breast cancers, triple negative makes up only about 15%, 15%. Okay, so it's the vast minority of breast cancer seen overall. However, there are certain groups that have a higher chance of developing specifically this triple negative breast cancer and are at higher risk for developing that subtype of breast cancer, which is more aggressive. Black women is one of those groups. So Black women, when they develop breast cancer, there's a 30% chance it will be triple negative, not 15. So it's much, much higher. And as a result of that, they're at far higher risk of developing one of these more aggressive types of breast cancer and may need to be screened sooner and earlier and with greater frequency because the death rate related to the triple negative breast cancer is much higher. In general, the good news is we have not seen a lot of pushback for women trying to get mammograms before the age of 50 at 40 when we recommend starting and yearly thereafter. But for sure, when these large government institutions like USPSTF and even American Cancer Society start, messing with our recommendations, there are insurance companies that do sit up and take notice and can use that as fodder to deny mammograms. We at Mount Sinai here feel very, very strongly that women should keep to our guidelines, which are 40 and every year after. And we accept women of all insurance and even without insurance, regardless of ability to pay, and do everything within our power to make sure that all women, regardless of their ability to pay, get the care they need. So the argument against doing mammograms earlier and more frequently is for sure there is no perfect test, and mammograms aren't perfect either. And while they do find cancers, they do find background noise as well. And they can generate unnecessary biopsies and false alarms, which can cause concern and be a source of anxiety and so forth. But the biggest problem with these guidelines prioritizing those endpoints is they're very, very patronizing and they're very, very demeaning to women by saying things like women will decompensate, they'll get histrionic. Women can handle this. Yes, it is very concerning when a mammogram comes back as abnormal, but it's important to know that if a mammogram comes back requesting a callback, most of those are resolved with just additional pictures and without even getting to the biopsy point. Yes, a small percentage will need a biopsy, and yes, some of those will be normal, leading to what's called a false positive. But the anxiety related to false positive findings and the need for additional pictures, in my experience, is far less than the anxiety related to an advanced breast cancer diagnosis and the risk of mortality and all of the treatment that one might have to go through in order to save her life. There are exceptions. One of the things that where we've made so much progress in the world of breast cancer that I'm so proud of is the no one size fits all approach. And certainly there are groups where we might even start screening earlier. For example, women with a family history of breast cancer, particularly in a young age, may be told to start screening earlier and add other adjunctive tests like ultrasound, like MRI. These are all considered in our high risk populations. So, for example, if my mother had been diagnosed with breast cancer at 45, we typically advise starting screening about 10 years younger than when the youngest family member was diagnosed. So, I might be recommended to start even at age 35. So the recommendation is always as an individual, as a person, to seek personalized advice and guidance regarding screening, timing, and what type of pictures to get. The density notification is a super important step because what it tells women is, and their providers, if they might be at higher risk for having a cancer missed on a mammogram and potentially should be adding additional screening tests like ultrasound, like MRI, to close the gap in case mammograms are missing something. To me, what the most important part of this is knowledge is power, and women should be empowered to know more about their bodies. It doesn't automatically mean everyone needs an ultrasound or an MRI. It's a discussion, and it's a very nuanced discussion. But it is a data point that can factor in heavily into making these decisions. I think the most important thing, though, is that what's so ironic about this is that breast density can only be determined one way, and that's based on a mammogram. We can't tell breast density from a physical exam. We can't tell from someone's age. We can't tell by any other way, okay? We can't tell by someone's family history. And so in order to assess breast density, you need to get a mammogram. And so it's just so ironic to me that the FDA is telling women and telling these facilities, know your breast density, when the USPSTF wasn't telling women to even get mammograms. So I think we've got to put this all together in a way that doesn't send mixed messages to the public and leave them hanging regarding so many conflicting recommendations. I think to keep it simple, we do what our recommendations are, what we have recommended all along. They've been consistent, they've been clear, they've been based on data and research. And that's start getting mammograms at age 40 and continue yearly. And based on that mammogram and the knowledge of breast density, one can then have an educated conversation regarding whether or not any additional imaging is appropriate. Notification regarding breast density. So this is an interesting point. The notification regarding breast density, there had been multiple states with laws regarding breast density notification before the FDA got involved. So we were up to almost 38 states, I believe, that had breast density notification laws, and New York was one of them. So here at Mount Sinai, patients were already learning about their breast density. With the FDA stepping in and requiring notification, now all 50 states or 51 territories need to provide notification, and they need to do it in a very regulated, uniform way, which is the addition of a specific paragraph in the mammogram report that the layperson gets describing their breast density. So part of the other part of the pre-FDA was not only did 38 states have legislation, but the legislation was all over the map. Some required notification of the provider, some were giving the information to the patient herself. And so this makes everything, again, much more consistent and clear and uniform. For the general public, primary care providers and gynecologists for women really are the ones who are ordering most of these tests. And, my feeling is if someone's primary care provider, like any cancer screening test, that is their main role to customize and personalize and tailor um, any kind of cancer screening modality based on the individual, that person's family history, that person's age, that person's other medical issues. And I think that that's what a good doctor does, is takes all of these considerations in and puts it all together in a thoughtful approach for the individual where there's no one size fits all.